made the flyer and the video.
Yes.
Neenal, 11 वाजून गेलेत. So whenever you say, we can start. Huh?
Please start. Please start. Yes. मंजिरी तू हे आहेस म्यूट आहेस.
Yeah, I'm starting.
Yeah.
Good morning, all. First of all, happy World Anesthesia Day to all of us. We have completed 75 years of ISA this year, so we are celebrating it. Today, on the same occasion of the World Anesthesia Day, we are having this small online academic meet. Of course, we are releasing our e-bulletin, Samvedana, Let's Talk. I invite our President, Madam Dr. Meenal Gadgil, to address the meeting.
Thank you, Manjari. Thank you so much. And I welcome all of you for today's auspicious day gathering online gathering. And for this day, since last 15 days, we are doing lot of activities and we are actually celebrating so many things. And we have enjoyed the whole journey. And today we are so lucky that our theme is World Anesthesia Day with the Children Care. And we have Dr. Dilip Savan with us. So I welcome him for our session. Welcome, Dr. Dilip Savan. And today I want to welcome Dr. Vaishali Vavikar, who has taken the responsibility of e-bulletin. And all my dear friends, everyone has taken efforts for today's gathering and for this 15 days. So I really welcome all of them who have joined here, and I hand over to Manjiri. And before that, I want to tell everyone happy, happy, happy World Anesthesia Day. Thank you.
Thank you, President Madam. Thank you, Dr. Minal. Now I welcome our dynamic secretary, Dr. Manisha Ghosh, to address the meeting.
Thank you, Manjari. I will need to share my screen. So first of all, good morning and a very happy World Anesthesia Day to everybody. I liked somebody's greeting very much. Happy Vada Divas. So W-A-D Vada Divas. So it was like a double thing. Vada ka greetings also and Vada Divas also together. So that was really nice. So it was exactly 1 year back on the 16th of October in 2021 when we released the first edition of our e-bulletin, and it was received with a lot of warmth by everybody. We wanted it to be a quarterly issue, and I'm very happy that we have been able to deliver on time each and every bulletin, this being the 4th of the year. So the editors have changed. I think everybody has realized what fun it is to edit a bulletin. So when I requested Vaishali, she very, very happily took up the responsibility, and thank you, Vaishali, very much to it. This year has been very fulfilling because we've had lots of CMEs, all of them online given the pandemic. And we realized that CMEs online receive a lot more response than offline. Plus, we are able to invite faculty from all over the world, and that has made it really very simple for us. In addition, we also had offline activities like the narcotic beats and our Cheers with Dears party. Our membership has also grown. We were, I think, 80 last year. Now we are 102. And I'm very thankful to Dr. Meenal Gadgil for her constant support in making Thane ISA stronger. Now, since World Anesthesia Day was approaching, some thought came into mind that we should do something about awareness. So I started giving our team members a task to be done every day. And after giving those tasks, I realized what a task it is to give them a task. But I'm very, very grateful and thankful to everybody who participated. So I will just like to present a little overview of the things that we did. So let me screen share. Full screen, Gara? Okay. Yeah. So these are what we did this year. So every day there was one task. It's not moving, Gucha. Yeah, so this was a very different and unique thing for our member anesthesiologists, and they could do it sitting in their OTR at home without having to put in any extra effort. And it was really nice that many of them participated enthusiastically, shared photos and all. So this is a nice thing, 2 posters that we made. This specifically shows that we received the flame from Kalyan, then it stayed in Thane and then moved over to Borivali. So all the landmarks of these 3 cities we highlighted in this banner. And then of course the task, the first day was anesthesia machine. Then we moved on to COLS, which is our flagship program. Then we did Shastra Pujan because that day was Dasra, so that everybody participated and thanked their tools for making their life simple. Then, of course, with work, we need to distress also. So we attended this nice drama, which was presented by IMA and TOJS Police, which was very nice. Then we had a meeting to plan everything. Then we talked about our instruments. And then TOJS invited us for a CPR program, which was very, very successful. It was very interactive and everybody really enjoyed. Then there was another thing which we kept about knowing our drugs, explaining to our staff. They should know which drug does what and keep everything ready. Then anesthesia awareness fitness, we welcomed the Jyot from Kalyan. Then we took it around the city to 10 different places, which was very wonderful and everybody received us so warmly. It was really nice. And then we had a day of relaxation after the hard work. And then we registered for ISA Borivali. So we have almost 15 to 20 people from Thane who are going for ISA Borivali, and we've planned something special for them. Then we use social media to highlight ourselves. And then this is an overview of the activities that we did. So thank you very much. And I'm very happy that everybody participated, and thanks a lot. Over to you, Manjiri.
Thank you, Manisha. Now I invite Dr. Parna Thakkar to present a PPT on the history of anesthesia. I think Parna has not been able to join, so we will play the PPT because she's in Delhi with the national event. So I request Dr. Manisha to.
So Varsha will share the screen for that. But so we always, when we go for COLS activities, we always talk about COLS and what anesthetists do. So this time we've decided that we will include something about the history of anesthesia, so the public is aware of how anesthesia actually developed. So this is just a small PPT that Parna has made, which we will be including in all our COLS activities. And thank you very much, Parna, for that. Varsha, you can just start clicking to next slide. So how in olden times patients were tied, or they were just giving poppy seeds and datura. Next. Then how on 16th October, the first public demonstration of ether anesthesia was done by Morton. Then how it developed to ether and chloroform was also introduced. Next. Then who is anesthesiologist? We have been behind the screens. We were only peeping. Now we are going to come out from behind the curtain and explain to the world what we are. Next. So of course we work in ICU and OT. Next, Varsha. The different types of anesthesia that are given, that also we will explain: local anesthesia, regional anesthesia, general anesthesia, spinal anesthesia, everything that we do very briefly, and how we are very, very important in epidural labor analgesia, because patients are now becoming demanding and they want labor analgesia also. And how we work, what we do during the time of surgery, that also we will explain to them. Next. So anesthesiologist is actually the lifeline of the surgeon. And then how we do the BCLS and ACLS, we will explain in brief, because that is what that program is about. Jivan Sanjeevani. Every citizen a lifesaver. Yes, Varsha, next. I think we are done, na? Yeah. Thank you very much. And thank you, Parna, for that lovely presentation. Manjiri, over to you.
Thank you, Parna, for this lovely PPT. We anesthesiologists are known for to manage stress, pain perioperatively. We are perioperative physicians. Our achievements, our feelings, our stress busters, all are included in our own bulletin, Samvedana. Let's talk. Today, we are releasing the 4th edition of our e-bulletin. We have our guest of honor, Dr. Dilip Savan. He is very well-known pediatric anesthesiologist. I invite Dr. Dilip Savan and our own Dr. Vaishali Vavikar, editor of our e-bulletin, to do the honors.
Yes.
Yeah.
Everybody could see?
Yes.
Shall I share the bulletin now?
Yeah, yes.
Please.
Please go ahead.
And this is the bulletin. Yeah. Okay. So this is the bulletin. I'll just scroll through it.
Yes.
tried to include all the activities which have happened over last 3 months. The major being the Constitution relief, and of course, the last 2-3 days was full of ISA flame journey. The enthusiasm was infectious all over Thane city. Yes, that's it.
It is not, that's it. You have done a wonderful job.
Thank
Very
you. Thank you
nicely
so much.
made. Even I have seen it for first. Yeah, very nice, very nice. All your creativity can be seen.
Yes, thank you. Thank you so much.
Thank you, Vaishali, for this lovely
Manisha
bulletin.
कुठे आहे? हा.
Yes.
Should we proceed?
Manisha कुठे आहे?
आहे ना.
Manisha is there. Manisha mute वर
आहे
आहे.
आहे 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 मंजिनीला आहे.
मनीषा होती ना माझ्या पाठी, भिवू नको, मी तुझ्या पाठीशी आहे.
I know. But Vaishali has done a wonderful job really with no trouble at all. Hey karu ka, te karu ka. She knew what has to be done and she's done it very, very beautifully. Thank you, Vaishali. I hope you will continue to be the editor, huh?
Yes, yes, yes.
Thank you
My
so
pleasure.
much. Thank you, thank you.
Should we proceed?
Yes, please.
Yeah. Thank you, Vaishali. Thank you, Dr. Dilip, for releasing that beautiful e-bulletin. We, Thane ISA, is very fortunate to have Dr. Nilima Kerkar as our scientific secretary. I hand over the proceeding to Dr. Nilima for our scientific session.
Thank you, Manjari. Thank you, Dr. Vaishali, madam. That was really beautiful bulletin. It is a great pleasure to introduce Dr. Dilip Chavan sir, especially on World Anesthesia Day, as the theme today is keeping our children safe. Sir is Director, Children Anesthesia Services, Mumbai. He is co-program leader, WFSA Pediatric Anesthesia Fellowship. He is co-program leader, Aura Pediatric Regional Anesthesia. Sir is working as pediatric anesthesiologist since last 2 decades. He has special interest in difficult airway vascular access and regional anesthesia in pediatric age group. He is faculty in pediatric anesthesia in various conferences. Sir is co-author with Professor Marraro's book on pediatric mechanical ventilation. A very warm welcome, sir. Dr. Dilip, sir. Sir will share his experiences and guide us about safe anesthesia conduct in pediatric age group. Dilip, sir?
Yeah.
Yeah.
First
Yeah.
of all, thank you all the organizers of our Thane, because I feel that this is very close to my heart, Thane. Anyway, I stay in Thane, I work in Thane, and it is a really proud moment that you people invited me for this inauguration function and the talk on pediatric anesthesia. Thank you very much. And Dr. Vaishali, it was a really nice bulletin, and then a very nice formed. So I think so we should continue with this bulletin every fortnightly or whatever we are doing, and then whatever it is possible, even I can share my few cases which I am doing since last so many years, few research work which is we are doing, that can be also shared in our journal.
Thank you, sir.
So nice of you, sir. Sir, I would like to ask you first, how you got into pediatric, how you got interested into pediatric anesthesia?
This is a very nice story because I am from BJ Medical. So one of my teacher and mentor, she was doing one cystic hygroma case, which why I got so much interested, because I was the last person, because I was in the first year, and then day before doing that case, we were like so busy in making the drugs calculations and so on. So and and then the things which we make it clear, okay, this was a cystic hygroma, which I can share you. Then so that day when we started that case, it was so much difficult for us, every one of us, that so I thought, I was wondering, because anyway that was a 3-month-old child with cystic hygroma, and It was extremely difficult intuition. I'm talking about this is 1998, where we didn't had a fiber optic scope. So if that would have been situation, it would have been a different thing. But then I realized that this is something very different subject. This need to be seen. So then I started wondering where to do this pediatric anesthesia. So in a second year, then I realized that in Mumbai, Wadia Children's Hospital was there, and then there are in abroad, they were like, I thought there are pediatric anesthesiologists outside, there are neonatal anesthesiologists outside, and then why can't we have a here specialized people? So then I decided to join one of my seniors. She told me that you should join Wadia Children's Hospital, and then you should see over there. There is a lot of pediatric work is going on, and then I joined in 2000, and then there afterwards, like I started, okay, then I within 6 months I realized this is my subject where I want to make my career, and then went ahead with so many things. So this was my journey, a little case, small case, which triggers me that this need to be, believe me, pediatric anesthesia is a really a simple thing. There are very few minor things which you need to taken care of. If those things, if you can manage, I think so anyone can manage pediatric anesthesiologist. We have started almost, me and my colleague Dr. Shali, we have started uh, creating awareness amongst, we try to take the students who are from the rural area, because our main prime purpose is that even in the rural part of the India, each and every, even a small boils machine, if they have, they can do neonate with that much confidence, which is why we are trying to give. And we have created almost, I can proudly say that almost around, we got our students all over the India, not from the India, even from the abroad. We get the students each and every year, and they are doing phenomenally well. And pediatric anesthesia has gone to the rarest of the rarest place where it was initially too much difficult to give anesthesia. Now at that ease, people are giving anesthesia in those places.
Okay, that was wonderful, sir. Um, Actually, I have observed, sir, during some of his cases. So I can vouch for it that he makes it so simple and he does it so effortlessly. So I think we will learn from him some few tips and tricks of pediatric anesthesia today. Sir, I would like to ask you how to deal with separation anxiety in kids, especially in 1 to 5 age group. Which anxiolytics should we use and how to use?
So before because I am here today, I want to just share here. I'm in Goa because uh, this is a national conference of pediatric surgery happening over here, with along associated with the SARC association, and I conducted pediatric airway workshop for pediatric surgeon here. Since last 3 days I'm here, and 2 days I'm here, and then taking their courses on pediatric airway. The pediatric surgeons are so happy over there that the anesthesiologists are taking over and giving lectures to the pediatric surgeons, because I felt that airway is that subject where whether you are a physician, whether you are an anesthesiologist, whether you are a surgeon or anybody else, you have to know at any cost. This is what then our pediatric surgeon organizing secretary, she said that we need to have this sort of courses in even in a pediatric surgeon. I felt really proud that even the other faculty has also started recognizing the strength as an anesthesiologist, and they are inviting to us in their conferences and telling them that you must teach to this our pediatric surgeons. I just want to share the video where they share today morning, because today is the World Anesthesia Day. So she wanted, I told her that I am going to have a meeting, an online meeting, and then they displayed over here in front of all surgeons, and they wished all our anesthesiologists a World Happy Anesthesia Day. I just wanted to share. Can I share my screen?
Yes, yes.
Good morning. I am Dr. Z. Market from Mumbai. I am a pediatric surgeon. There are a lot of silent warriors in our operation theaters, because of whom we can do good surgery. These silent warriors are our
You can hear?
anesthesiologists. they don't get much
Yes,
vitamin
sir,
C.
we
We
can.
can hear, but there's no video, right? Only audio, right?
Yeah, video
Yes.
is also there.
Today on the occasion of World Anesthesia.
So this is what, and then madam, what you said that I got, see, we can make little bit our session interactive if anybody wants to have a question or doubt. So I got this one as a tricks of trade in pediatric anesthesia. There are few things which I feel that we need to get pointing out. So as you said that, uh, first of all, what I feel is that we are very scared about the kneel by mouth status, because we feel that I have seen that people keeping NBM children for more than 12 hours. Absolutely, it is a very criminal to have this one. So what I feel that uh, fasting guidelines are very clear cut. So if you see, this has been now proven, everything has been proven that uh, clear liquid, or what I usually prefer to give a coconut water to these children for 2 hours prior, because basically in a summer season it makes a very horrible thing because they are dehydrated, and then it becomes their life really miserable. And when you take them for a over room, most of the time patients happen is that when you try to do induction, they are into the like little so dehydrated, and then severe tachycardia is happening. When you see the NIBP on BP, you see the lower side of the. So what I feel is that clear-cut indications for the fasting guideline is that you should keep kneel by mouth 2 hours prior to the surgery. That either if you feel that child is not able to console, you can give a coconut water. If you feel that for a neonate or breastfeeding babies, 4 hours is the guideline. 6 hours. I am practicing, even we are practicing in this sort of guidelines since almost last 20 years. So this is what I feel. Then as madam, you said that we need to pre-medicate these children. So it's a very easy. Midazolam has proven. There are a lot of pre-medications which has come into the market. Finally, which I feel that midazolam has much more advantages over any other pre-medications what we give. So the oral route, if you have a time, you can give midazolam 0.5 milligram per kg. You get an ampule, 5 ml, 1 ml contains 5 milligram. That ampule can be used. Or you can mix with a little bit of honey or something with the dextrosaline, little small amount, and you can give. Some most route I prefer usually to give midazolam if you are little bit, if you want to make the child little bit sedation earlier. So you can give intranasal midazolam, that is a 0.3 milligram per kg. And if IV line is there, you can give midazolam and ketamine combination. That is one of the best thing what you can prefer. So this is what usually we try to give.
Free of. Sir,
This is
any
what.
vagolytic you advise or no?
Yeah, pardon.
Any vagolytics you advise or no? No role of vagolytics now.
No, nowadays we don't use any anticholinergics. You mean to say?
Yeah.
Yeah, no. We unless and until child is having URI, I don't prefer to give any sort of. I think so. Even in adult also, you must have stopped using anticholinergic drugs. In same thing is happening in the pediatric. Unless and until child is having URI, we don't use now any anticholinergic drugs.
Okay. So since you are talking about URI, let's come to the usual dilemma for anesthesiology. When child is having URTI, whether we should go ahead with the case or what, postpone the case. So what are the criteria?
So to be very simplified, there are criteria there, but I can tell you that if child doesn't have any fever, and on auscultation, if child doesn't have any rhonchi or wheeze, I think so you can go ahead with the case. This is what as simple. If you calculate the formula, uh, every third week child is having URI. So and then if you see our norms, once your child have a URI or you are LRTI, you need to postpone that case every for a 3 weeks. If this happens, then you will never, your case will never come on table, because according to the what we say that every third week till the age of the 5 years, children undergo either they have a little running nose or mild dry cough, which will be there. I think so. simple you can keep is that if child doesn't have fever, on auscultation, doesn't have wheeze or any sort of conducted sounds, you can go ahead with the surgery.
Okay, okay. So that clears her doubt. Sir, airway concerns in pediatric age group. Can you little bit?
So one of the most important thing which I feel is that which is my observation, and then when we see, most of us we make a mistake in holding the mask. That is what I think. So bag mask ventilation need to be learned in a very proper way. We sometimes we try to hold it in such a way proper. So what I do is that when we start the induction, it is always we say that EC clamp technique, but usually when we start the induction, we try to keep the mask. Let me see if I got a video, I can just show you how. So this is the way the so this is how you should be doing the inhalation induction. If you see here, so see holding the mask on the upper end, and on the opposite side, never try to hold on the angle of the mandible unless and until child undergoes deeper plane of anesthesia. Till then, you should be holding the mask in a C technique and half E, where you should not keep the mask on the angle of mandible. That is how you should be doing, because if you try to in that margin, you are giving a, whether it is a halothane or whether it is in a sevoflurane anesthesia you are giving, and then in middle of the something which you try to be patient in a lighter plane of anesthesia, if you try to hold, patient will go into the laryngospasm. So I feel that bag mask ventilation is an important thing which we should again and again we need to concentrate on this technique and start doing. Once the beginning is a good, I think so you go ahead with a better anesthesia. Then there are few after that. Once the inhalational technique is done, then you need to make an IV line and then giving a regional anesthesia and those sort of things.
Sir, sorry to interrupt you, but we could not see the video.
You are not able to see it. I can again run, no issues. So this was like I had given a sedation to this child, so they accept so easily. So I feel that pre-medication plays a very important role in pediatric anesthesia, because they accept the mask induction very easily. Once they are into the deeper plane of anesthesia, just see the eyelashes, the plane, tie the mask. So this is the what we do mask technique.
Seen yet.
Video?
Not seen.
Oh, let me share the screen again.
I have stopped sharing the screen, so you should be able to share it. Yeah.
Okay, can you see now?
Yeah. Yes. Now we can see. Yeah.
So this is what I think. So we got a face mask each and every theater. Nowadays we're getting a disposable one. So what I do is that, so this is you tie the mask halfway. So if you see here, the first knot is from the middle, exactly on the middle of the ear. So you tie, you see the back movement. It is feeling very well, and then you see the movement. So once the patient in a deeper plane of, can you see all of you?
Yes, sir, we can see.
Sir, can you?
And then the second mask, just to tie one. It is so easy. If in case of there is a spasm, you can just pull off the knot. It goes off easily, and then if you want to intubate or if you want to give a good CPAP, that is what you need it. So this is as simple as it is, because when you see, it is very easy to, because sometimes if you feel that this is really what we say that it's a complicated holding of the mask, but believe me, this is what you can see on the ETCO2 also. The patient is regularly breathing. So this hernia, simple mask we can use for a hernia, circumcision. There is no need of intubation in these children.
Sir, I want to ask you something. If we are using inhalational technique for anesthesia, and if the IV line is not secured, means we are planning to take the IV after the child is under, and suppose the child goes into laryngospasm, or if there is bradycardia, then how should we tackle it?
Okay, good question, because this is usually uh, let me see if I got a. So usually what you can do is you can either you increase the CO of urine and give a good CPAP, hold the CPAP mask and try to break that laryngospasm. That is most important thing. Secondly, or you can just switch off the CO of urine, just give 100% oxygen and try to hold it in a better way. At one point, do not get scared. Even there is a little of desaturation which happens. At one point, cord will get relaxed, and then again you start gentle ventilation. So automatically it picks up the saturation also. So it's a matter of so what happens once the saturation comes down, we start getting scared. What is happening? So in that situation, you give a good CPAP, give, and in case even with this one, if doesn't happen, your the spasm doesn't get relieved. What you can give is that just straight away give a IV choline and then you finish it off, and then it can come up. So that is how it is. It is so important to hold the mask. So that's why I said that mask holding, we are forgetting the technique, proper technique of mask holding, and that's why we are landing into the problem. So this is the important thing which we need to know, and then you can go ahead with any other future thing, because with this modern era where we induce the patient immediately and then we try to put supraglottic devices or whatever it is, but we but we are forgetting the basic technique. I think so we should again go back to our basic technique and learn much more in a better way. That is what I feel.
Okay. And sir, for bradycardia, and if there is no IV and the bachu goes into bradycardia, then how to do it?
So basically, you must remember what is the cause, because there is a hypoxia. So what we need to give a good oxygenation. That is most important thing. Sometimes a lot of people they try to give some atropine IM or this one. As I said earlier, that at certain point of time, cord even in the hypoxia, cord get relaxed. You start giving the gentle ventilation. Definitely it will come. Believe me, I must. Last year we completed 1 lakh cases. I can show you that how many complications we did and how many were the issues with the things. As again I'm pointing out that the mask technique is an important thing, and then you make the saturation up. So holding up in a proper way and then giving a back mask ventilation is the key of when patient goes into the hypoxia. Once the hypoxia is cleared, automatically even the saturation, even the heart rate comes up.
Okay, okay. That is a very good point, sir. So now about airway, anything more you want to add in airway management?
Let me see. Okay. No, that is what it is. So I got videos for the difficult airways. As I said, let me see. I can share something which is.
May I just say something till then? I have seen Dr. Dilip, I rather talk to him. And so initial starting of the practice, I think we used to intubate every patient. Then we moved to laryngeal mask airways. And now we are managing without any airway manipulation, just by holding the face mask and keeping it in place in the correct way and giving regional also simultaneously. So I think unless and until it is some heart surgery or brain surgery or laparotomy, most of the patients you are doing without manipulating the airway. Am I right, Dr. Dilip?
Yes.
Yeah.
So I just want to share intubation because I will share this video because I am going to show on a video laryngoscopy why it is important. So there are few points. Uh, uh, there were a lot of misconceptions about the intubation technique. What we feel that we used to keep shoulder roll below the shoulder. We used to keep a roll or shoulder pad below the shoulder. This one. I feel that if you try to keep that one, you are again making your life miserable. That is one thing, because already in neonate or a pediatric patient's anterior is larynx, and again you are making two words. So your laryngopharyngeal axis doesn't come in the same plane. So here today I'm going to talk about few tips. What is most important thing is that as I said, this is, can you see this? This is the head ring, So which stabilize the head, and it gives a good so once during the intubation, so head doesn't move. That is one thing. Secondly, there is no need to keep any shoulder roll below the shoulder. So that is how. And once it is done, so you can just easily just open the mouth. You can just watch this video, and then another things which we try to keep so hard, we try to keep in such a rigid way. There is no need to keep anything. Pediatric is such a simple thing. Just if you can see here, my holding the scope, you can see very easily. I hold the scope, and with the little finger, try to practice with your little finger maneuvering of larynx, because see what happen if any the assistant, if he's trying to, because he will say every time, "Arey, move on the left, arey, move on the right." So what technique what we have developed is the ring head technique, and then with the little finger maneuvering. So if you can see my hand, so I'm maneuvering the with my little finger, and then it becomes a very easy way of intubating the patient. So it is important not to keep shoulder roll, because you again worsen your the intubation or the axis, which doesn't, all three head ring gives a stabilization, and it will help you out for the easy intubation. And with the little finger of manipulation, it really helps. You can, from tomorrow onward, you can try to practice this sort of things. You will and then you will tell me that this is the most easiest way of doing the intubation.
Okay, sir, that was great. Sir, any comment about whether to use cuff tubes, uncuffed tubes, or micro cuff tubes? Any comment about that?
Yeah, this is very close to my heart, because my mentor, Dr. Andreas Gerber from Switzerland, even I had a little good inputs in around in 1998, when he had developed this microcuff tube. I feel that each and every one of us should start using the microcuff tube, because it has got a lot of advantages. One thing is that the most important point about the microcuff tube is that the cuff is made up of polyurethane. So it gives a good, I can show you the image of the tube. Uh, Let me see. So the thickness of the microcuff tube is 10 micrometer. So it exactly fit around the tracheal mucosa lining. So advantage is that less tissue trauma, and what we see exchange rate with the um, this is what. So if you see, exactly it feels. So we had done the study of dye injected, and then we did a CT scan study. If you see the microcuff tube, where absolutely zero aspiration, and if you can see the PVC, because PVC cuff thickness is almost around 20 to 25 centimeter of water. So the thickness. So the exchange rate, and for example we do a lot of neonatal surgery, CDH or TIF cases, or we required a good ventilation. So in this patient, so microcuff tube gives a lot of great advantage over any other tube. So only thing is that we need to keep the cuff pressure manometer, which is easily available. It is not a very expensive one, and intermittently you can just check the pressure during the anesthesia or post-operatively when you keep these patients on a ventilator.
Okay. So they are easily available, microcuff tubes?
Yes, absolutely easily available. You can just contact, because now this has taken over by Avanos group of company, where you can use. So it is available even in the South Polar tube, where if you want to use in a cleft lip and palate cases, you don't need to do a throat packing. Microcuff tube helps out in a very bigger way. when you're doing a cleft lip and palate cases.
Okay, okay, sir. So anything about choice of IV fluids in pediatrics?
What we need to know, see, it is important that what I use is a ringer lactate, unless and until it is a contraindicated. For example, in renal cases or so, where or renal failure cases, then we use a normal saline. This is the only choice of the fluid I think so we should use. Very simple way, what you can do is that we keep NBM, as I told about the NBM status of like 2 hours and the 4 hours and the 6 hours for the solid food. So what fluid what I give of renal lactate is for the initial first hour, for a minor cases is 10 ml per kg. For supra major cases like a laparotomies where there will be not a fluid loss much more, where we can give 20 ml, 15 ml per kg, and then in a supra major cases where you're going to see a lot of blood loss or fluid shift is going to happen, then we give 15 ml per kg. If you go back home and then you watch our traditional formula 4-1, it comes around the same thing. So what we have made this use of IV fluid is that very simple way: 10 ml per kg for a minor cases, 15 ml per kg for a so major cases, and supra major cases. What we do is the 15 ml per kg.
Okay. So do we need to add any dextrose, 1 to 2% dextrose?
Absolutely, it is not required. Even in the liver cases, when we give, or extremely preterm babies also, when we give anesthesia and when we do interrupt their sugar level, it has never ever I had seen that it has been reduced, unless and until a very chronic liver failure patients, which is we are doing, or in that cases only. Otherwise, normally you yourself can check when you are doing the cases with, you get a the random sugar level, just check during the intraoperative cases, and then you see it will never ever you see the drop in the glucose level.
Okay, that's a very valid point to remember, sir. Sir, I remember during our PG days, we for drug dosing used to make those charts and stick on the boils machine. So any tricks to remember drug doses in pediatric age group? Or
It
should
is
we
very
focus-
simple. Believe me, I have formulated this formula. It's a very so we get a 1 cc syringe. We get a 1 cc syringe, and actually I can't tell you, but most of people who have worked with me, they know about this one. Believe me that 1 cc has changed the life of each and every person who have worked with me. No need to calculate, absolutely no need to calculate any formulas of the drug. Like I can say you that the dose what we give for a glyco is 4 microgram per kg. So 1 cc contains, so we calculate 1 ml of drug contains almost around 200 microgram. So what we do is that I calculate, so there are markings on 1 cc syringe. I am not here, otherwise normally if I was in the hospital, I would have shown to each and every one of you. So then there are like twice the weight, small marks, what we do. Initially for 2-3 cases, you find it little bit difficult. And once it is known, then you can just, there is no need to think. For example, tomorrow, you get a child of 2.75 kg. There is no need to go back, write on the paper that atropine, glyco, 2 into 2.75 into 5. Because what we make is that we are just into that drug dosage calculations. So half our mind goes into that one. So I have made, so if any time we physically meet, we have a physical meeting, then during that time I can show you how we calculate, I calculate the drug dosage. For each and every drug, I got a simple formulas where you have to use only 1 cc syringe till 20 kg. After 20 kg, I think so we don't have any problem with any drugs. But till 20 kg or for a simple neonatal patients, we need to be very cautious about. Secondly, I would like a good question you asked. I would like to urge for each and every one of you is that never ever try to drug. See what people they try to take a glyco and then dilute up to 10. Then they will take a midazolam, dilute up to 10. Is that bargain? Believe me, you never give a accurate doses. So either use a smaller gauge, need a smaller size, like 1 cc syringe or 2 cc syringe for the drug dosage. Then and then you can give an exact accurate dosage. Because what happens, we keep a lot of syringes on our trolley, like with filling atraquarium, taking then 25 milligram, then again diluting up to 10 cc syringe, and there are a lot of syringes are there. So which creates a lot of confusion when you are giving anesthesia. So it is important. Once, definitely, if I meet all of you personally, I can share this formula, because I want, because a lot of people they got issues with the drug dosage system. So when we meet physically, definitely I will share this one with all of you.
Sure, sir. Next time when during physical meeting, you can show this. Sir, now moving on, what do you advise whether we should do awake extubation or deep extubation? In freelancing, we prefer to do awake extubation because we don't know how the nursing staff.
Very clear cut. If you are not an experienced person, always extubate child in awake condition. Do not hesitate, because it is an important thing. Unless and until you are experienced of doing, I usually prefer patient deep extubation, because I want children need to be calm when they go out in the recovery room. They should be absolutely in a because nowadays when I talk to my patient children, they usually, most of, like nowadays they are so much demanding. They want that I need to be sleep in my mother's lap, and when I come back from the operation, I want near my mother in a sleeping condition. I don't want to see anything. This is what sometimes nowadays children they demand. So what usually my practice is that I extubate deep, but my clear cut instructions or whatever the suggestions will be that if you are not experienced, please do awake extubation.
So during awake extubation, sometimes there is problem of coughing, and also how should we avoid that coughing and spasm?
So what you can do, one of the simplest way is that once you, so extubation, during the extubation, what you can do is that you give a good little bit CPAP. When you remove the tube, give a good CPAP, so then patient will not go into the spasm or coughing. It will happen. Usually coughing happens when you got a little bit of secretions or it is there, then and then child will cough. Otherwise, there should not be any issues with the extubation.
Sir, in post-operative period, what are the commonest causes of hypoxia in kids?
Most, I usually, if you do the surgery, always keep patient in a lateral position, because in case if the patient, if there is a flexion or something which in a deeper plane, what you can do is that hypoxia is the only cause where is the reason either laryngospasm will happen, or because of pain patient will have a can have a vasovagal. So you should giving a good regional anesthesia. Now this is an era we are moving from opioids to non-opioids. I feel that each and every one of us should know good. Pediatric is a very simple thing. There are only two things I want each every one of you should know. Caudal, you can give for any surgery. You can give for a laparotomy. You can give for any lower limb surgery. You can give for a circumcision. You can give for a hernia or orchidopexis, any sort of surgery. And secondly, if hand case is there, one has to know by heart whether you got an ultrasound, whether you don't have ultrasound. You should know axillary block, because most of our cases are the hand cases where fracture radius or you see a lot of injuries or syndactyls, these sort of things, where you should know how to give a good axillary block, and you should know how to give a good caudal block. That is what I important thing. With all this one, definitely your post-op complications, 100% I can vouch that you can reduce all these complications. And post-operatively, I think so you should keep patient in a lateral position. So that will help out. So it clears the airway or any secretion which comes on the lateral side, and patient can be in a better way.
Okay. Sir, as you are talking about regional, are you using ropivacaine now or still bupivacaine?
We are still because our personal experience as a pediatric anesthesiologist, not only me, because as all of us, when we are we try to use ropivacaine, but we found that little bit of motor action was not much that of beneficial. So we have stick to the combination of bupivacaine and the liponicane adrenaline, which we are still using. And we had not seen any cardiac issues or hardly one or two patients long back. We had problems. Otherwise, normally even with the bupivacaine. So what we do, if we are exceeding the dose, we change our technique. Like for example, from caudal, if I feel that for a 20 kg child, the volume is too much more, then I shift to a technique of giving the epidurals. This is what nowadays. Almost last 10 years, we are very site specific. For example, even for the neonate, if any thoracotomy or laparotomy it is there, we give thoracic epidural or lumbar epidural in the neonates.
So you are using a single shot epidural or do you use put catheter?
Pardon?
You are using single shot epidural or you put catheter?
Yeah, we put a catheter. Let me see if I can share the video and you can see. So many things are there to share. This is the caudal video.
So sir, caudal and axillary, these two things.
I can show you the caudal one because I got this is a neonatal caudal video. So very simple technique where you need to let me stop here. So we need to palpate the PSIs, and then you can keep your thumb on the sacral hiatus, and then you palpate for the sacral cornu. So what I try to, for example, these are the sacral cornus where palpate with the thumb, and then exactly you keep at the mid of the apex, and then you go. If you try to go too much at the apex end, where you will enter into the bone, or too much down, again you can go into the bone. So exactly what you can do, just feel over the cornu, feel the last end, the end of both the cornus, and then you can go ahead. So once you go, sacrococcygeal membrane is so peppery thin in the neonate. You get exactly a peppery thin. Once you enter, like how you puncture the paper, it is the same thing. You get a click sound, wet over there, and then you can go. So this is the way you should be giving aspirate in between, and then you can give the caudal block. Again, a very, very simple block to learn, and you can get away with all lower limb surgeries and the hernia circumcision. I feel that each and every one of us should know this sort of blocks.
So anything else you want to share with us?
I just want to, 1 second. So yeah, treatment of laryngospasm wanted to see. So I just wanted to share when spasm happens. So this is the video where you can see the bag. Give a good CPAP, and then automatically saturation comes up. So this is the way you should be holding the bag and then giving the CPAP. That is what I would like to share. And then this is the way specialized maneuver, and then propofol. In case if you have an IV line, then you can give 1 to 2 milligram per kg, and the last resort which we keep is of scoline, that is 1 to 2 milligram per kg if IV line is there. If you don't have an IV line, 3 to 4 milligram per kg of scoline should be given. There is a special which thing what me and my surgeon Dr. Shivaji Mane, and you must be knowing pediatrician Dr. Parmanand, we are creating awareness amongst because a lot of people in the pediatricians. I take all over India these lectures on ischemic limb. Where because of accidental puncture of radial artery or brachial artery which happens and patient goes into the spasm, where I can share you that the cases where let me see where I can. Let me share you this one because this is so important, because I convince all the pediatricians. Now they know the management anyway. In the next week, please do come to Jupiter Hospital where we are. I am going to talk on IV extravasation and this is the damage control. But on World Anesthesia Day, I would like to urge all of you that when this sort of situation comes to you, pediatrician, if they call you, you should go there and see this patient. So there are few cases I will like to share, and then we will go ahead with whatever you say then. So what happens, basically they try to do a radial artery puncture or the brachial artery puncture, and because of this, you can see on the screen is see there is a bluish discoloration in the limb. And so what I give, I go to the PICU or NICU, give a simple good auxiliary. So in this child, I give a simple auxiliary block. You can see because of vasospasm, the once vasodilation. So what we give anesthetic drugs is like bupivacaine and the lignocaine, adrenaline. So this you can see good the change in the color. The hand is becoming the pink, and this was the final picture. Absolutely the pink hand. So on timely intervention, because most of my pediatricians are pediatrician in Mumbai or in the Maharashtra, they know about this one. Now in even India also, people they know about these treatment modalities. But they feel that, sir, you have taught us, but then about our anesthesiologists, they are the PICUs or NICU and they are not giving the block. I urge all of you that I must have saved 50 limbs from going into the amputation because of only a simple caudal block and axillary block gave in PICU and NICU. Because if you see, this is a lot of trauma caused to that physician, then there is a trauma to the parents, and then finally that small child, it just came into the world and is too much ahead of him. And then in that, with a simple management, if we can save the limb of that child, I think so he's going to be one of the best person, because if he's not able to write or do anything, so he's going to lose that limb. So this is the second case which you can see this child, they did a brachial artery puncture, and if you can see, so what I did in this child, I gave a infraclavicular block, ultrasound guided, and this was the picture of day one. Immediately after 45 minutes to 1 hour, immediately the limb started getting pink, and then again I repeated the dose. You can see the limbs, the hand over here. So this was the final picture. Absolutely only this finger, rest all other things. Believe me, this parent will never ever forget us, because we have given something very different thing to this child. So it is important. I urge all of you, if you get this sort of cases, if pediatricians call you, please go to the, just assess, see the child, and very simple thing, just with the blind technique also, you can give an auxiliary block, blind technique, you can give a caudal block if anything happens. So another case I would like to share here is the thromboid formation. So little bit story I'm going to talk about this child is that, so this child was 1 year old child and came in a shock because GI problems, so gastroenteritis, and then patient was in a shock. So it was in a peripheral nursing home. So they tried to save, so they were not able to get an IV line. So they punctured the brachial artery, and they thought it was an IV line. They got it, and then in that joy that they got an IV line, so what they did, they wrap everything. And since the patient was in a shock, what happened? They couldn't recognize whether it was an artery or it was a vein. The next day in the morning, when they saw this, the sister realized something, there was a fishy. The morning when they saw this one, so this was the condition of the limb. So then this was patient was referred to us because that pediatrician was aware. So what I did, I gave a put an infraclavicular catheter on the left side. You can see of the screen, infraclavicular catheter, and then we did the fasciotomy immediately. We tried to relieve certain sort of things. So there was already thrombus formation which was there. Point here was, if this child would have not given the infraclavicular block or catheter, this would have done as above elbow amputation. So what we help in this one is that at least we could do a below elbow amputation. This is what we could at least save the limb of this child. So this is what it is important even in the lower limb. So femoral artery puncture. So gave a condyle block, and you can see the final picture is that absolutely pink. So this was a 700-gram baby. So this is how it should be. Like, you should be aware of this sort of treatment. As an anesthesiologist, we can definitely help in these children and make their life beautiful.
Yeah, so fantastic and so satisfying, sir, this technique. Anybody else wants to add anything else? Dr. Katkare, sir?
Yeah, I would like to add. Can you hear me? Can you hear me?
Yes, sir. Yes, sir.
See, I joined Wadia Pediatrics in 1980, and that time I was practicing in Thane, and I worked in Wadia Pediatrics almost 2.5 years. And I was fortunate to do lots of pediatric cases without boils. Believe me, we did many cases without pulse oximeter. So still, good old techniques are good in the modern era also. Every anesthesiologist, you must practice a combination. Every anesthesiologist must practice art of looking at the clinical signs. Every breath sound is to be heard, seen, or felt. That was the time when we used to practice open ether. So when you are practicing in pediatric anesthesia, apart from pulse oximeters, capno, and ECG, just make your eyes and ears sharp to look at the type of breathing and the color of the patient. Very often, in a hypothermic child, if your pulse oximeter is not placed properly, you may not diagnose SpO2. Look at the color of the lips. Look, and this is very, very essential. Regarding IV fluids, we all are tempted to use isolate P. I request isolate P is not to be used intraoperatively. Am I right, Dr. Dilip?
Yes, yes. That's why I didn't mention about the isolate. I straight went with the
only pediatric. It is only pediatric. Yeah, it is only pediatrician solution for maintenance of the IV drip. Third thing, in a nursing home, Dr. Dilip, people like Dr. Dilip and other pediatric anesthesiologists are really expert in taking veins and managing airway. We are called in a situation where taking an intravenous access may be very difficult. You have to take a help of the people who are taking IV intravenous fluids, or rather intravenous cannulation from time to time. Even for that matter, don't feel ashamed to call a staff nurse who has worked more in NICU than you. She may be better at venipuncture. So this you have to be very, very careful. Then precordial stethoscope, I mentioned. Then I used to practice lots of lips and palates in Gujarat. I used to give you lots of lips and palates, Gujarat somewhere 83, 84, maybe till 86. Many surgical camps for lips and palates we conducted in various areas of Gujarat, where open ether was the technique we used to practice and put in the patients on an open ether and flax scan. Good smooth intubation is very, very essential. And Dilip has really mentioned holding a mask. We didn't have LMA, or we used to avoid LMA intubation. So holding a mask properly is a very good technique with the regional anesthesia. Then other thing which we used to get tempted, and kindly don't practice intermittent scoling.
Yes,
Yeah,
yes, definitely, sir. Yes.
yes. Lots of people are getting tempted not to use. You are lucky in area where you are not using pancuronium or flaxidil or tivoquirone for that matter. You have got a great muscle relaxant. Please don't get tempted to use intermittent suxamethonium. Intermittent suxamethonium plus hypoxia plus bad secretion, difficult ventilation, distended stomach can cause a catastrophe. So this can cause particularly removal of a foreign body, bronchoscopy. Please intubate. I would like to intubate the patient, give an adequate dose of longer acting muscle relaxant like atracurium, ventilate the patient properly, secure the airway. Intermittent choline can suddenly your patient will get a bradycardia and you get a, if a person gets a thought block, he doesn't know the anesthesiologist and there can be a catastrophe. So this is very, very essential. So regarding, and particularly when you are doing bronchoscopies, removal of foreign body.
Thank you, sir.
Sorry, am I talking? You want me to stop? No. Particularly doing bronchoscopy, please give, I would like to give injection atracurium, ventilate the patient properly, and at the end of bronchoscopy, intubate the patient again till the patient comes out of muscle relaxants. So surgeon would like to do, you will say 1 minute, I can see a bottom body and it can be a problem. So that is second thing which I mentioned and Dr. Dilip mentioned very well. Thank you very much, Dr. Dilip. And thanks to Dr. Manish and team for organizing such a wonderful talk. So sorry for mentioning my old thoughts, but another very essential is good preparation. Good preparation, adequate preparation, not that you keep the entire all sets of laryngoscopes and tubes on the trolley. Adequate, you just calculate the size because anesthesiologist, your theater assistant, they are bit tense when a new anesthesiologist comes and you have a pediatric case. So one should be people make sure that your anesthesia equipments are properly placed and properly prepared. At least please reach to the spot 5 to 10 minutes prior to the surgery. Get well organized and then only start the case. 2 suction machines, one for the anesthesiologist, one for the surgeon. Sharing a suction is also difficult. Proper size of endotracheal tube, suction catheters, fixing of the tube. And the most important thing in a difficult airway is a selection of a proper airway, lubricated airway. Your airway, what you are using, it should not be too long and it should not be too short either. That can cause a more obstruction. So you have to choose a proper size airway. Thanks.
Thank you, sir, for those tips. Thank you, Dilip, sir. That was really wonderful talk and you made things so easy for us. So thank you once again for joining in the celebration of WAD and for e-bulletin release. Thank you so much from Thane ISA and from all of us.
Thank you very much, all of you, and then we see you soon.
Yes, sure.
We should be having an offline session with Dr. Dilip very soon, I hope.
Yes, Manish.
I feel that each and every, because we are trying to help out our colleagues in a crisis situation, but I feel that more of where the peripheral, where we are getting, when we go to the conferences, we tell them that come for a 1 week with us. We can just show you what is the glimpse of pediatric anesthesia, and then you go back home to your place and then you can start the practice, because there are few minor things as even Katkade sir suggested, because you should never ever forget the old techniques which has been formed. I think so that should be carried out, and then yeah, definitely if anybody wants our help, we are always there, phone call away, and then we can get away with the case, because finally the patient safety is the most important thing.
Yes,
thank you.
Thank you so much.
Thank you. Thank you, Dr. Nilima. Thank you, Dr. Dilip. It was a very informative session and you really made pediatric anesthesia to look very easy. We go further. We have a lot of talent in our Thane ISA. Amongst us, Dr. Sunita Oak and Dr. Vaishali Vavikar are known to pen down beautiful poems. May I invite Dr. Sunita Oak, a senior anesthesiologist and of course a very charming and superb writer, to read her poem.
Thank you, Manjiri. Am I audible?
Yes.
नमस्ते। वर्ल्ड एनेस्थेशिया डे की आप सभी को शुभकामनाएं। इस शुभ अवसर पर मैं कुछ पंक्तियां पेश करने जा रही हूँ, डेडिकेटेड टू एनेस्थीसिया एंड एनेस्थीसियोलॉजिस्ट। कभी पेन फ्री समंदर, थैंक्स टू ब्लॉक्स, नार्कोटिक्स एंड नॉन नार्कोटिक्स। कभी सपनों का शराब, थैंक्स टू केटामिन। कभी पेन फ्री समंदर, कभी सपनों का शराब, कभी पहचाना सा प्रोपोफॉल, कभी भूला बिसरा पेंटोथल। ना समझो इसे बच्चों का खिलौना, मार्क माय वर्ड्स, ना समझो इसे बच्चों का खिलौना, ना है यह एक बूंद शराब। यह कभी शोला है, कभी शबनम, खौफ है बेमिसाल। देखो, ओटी एक बंद कमरा है, वी ऑल नो। ओटी एक बंद कमरा है जिसमें मरीज है, सर्जन है और एनेस्थेटिस्ट है। ओटी एक बंद कमरा है जिसमें मरीज है, सर्जन है और एनेस्थेटिस्ट है। सर्जन अपनी करामत कर जाएगा, आंख खुलते ही मरीज उसी को गले लगाएगा। सर्जन अपनी करामत कर जाएगा, आंख खुलते ही मरीज उसे गले लगाएगा। तू हिम्मत मत हार सिपाही, तू हिम्मत मत हार सिपाही, ऊपर वाले के अकाउंट में हो रही है खूब लिखाई। जब मरीज हंसते हंसते घर जाएगा, सर्जन मन ही मन तुझे ही तो सराहेगा। A few lines for the ISA Flame, a superb initiative. Anesthetist ठहरता ही नहीं एक जगह, you all know that. Anesthetist ठहरता ही नहीं एक जगह, सारी दुनिया है उसका घर। ISA की ज्योत से प्रकाशित कर दिया है उसने हर हॉस्पिटल और नर्सिंग होम। I would like to end with a spoof on a very popular Bollywood number. मजबूर थे हालात ओटी में और बाहर भी, मजबूर थे हालात ओटी में भी और बाहर भी, तन्हाई जकड़े थी ओटी में और बाहर भी। मजबूर थे हालात ओटी में भी और बाहर भी, तन्हाई जकड़े थी ओटी में और बाहर भी। कहने को बहुत कुछ है, चलो आज कह ही देते हैं हम। कहने को बहुत कुछ है, चलो आज कह ही देते हैं हम। कब तक खामोश रहे और सहे हम। दिल कहता है ओटी की हर रस्म उठा दे, दिल कहता है ओटी की हर रस्म उठा दे। दीवार जो पब्लिक और एनेस्थेटिस्ट में है आज गिरा दे। क्यों दिल में सुलगते रहे, लोगों को बता दे। हाँ, हम एनेस्थेटिस्ट है, एनेस्थेटिस्ट है, एनेस्थेटिस्ट है। अब आईएसए में यही बात है, इस ब्रांच में भी और उस ब्रांच में भी। धन्यवाद।
Thank you, Dr. Sunita. It was a wonderful poem. Our e-bulletin editor, Dr. Vaishali Vavikar, has also done a fantastic job for our bulletin. Friends, she is also very well-known poetess. Vaishali, can I know a name of your book which was published? I missed that.
Hey Mana. Hey
Hey
Mana.
Mana. So she has written a beautiful book which got published recently, Hey Mana. May I request Dr. Vaishali to read her poem?
Yes. Thank you, Manjiri, and warm greetings to all my seniors and my colleagues on this World Anesthesia Day. My poem's name is An Aesthetist. I am the unsung hero with no hype and fervor, standing between breath and no breath, a great valor. In my name only it's clear that I numb the senses. Oh, just that is one just factor. What about the countless jugglery between tubings, drugs, circuits, screens, one whole OT sector? While the operator takes the credit galore, the head end is left without a splendor. The head end is left without a splendor. Every case comes with unfathomable risk, not a slightest chance of error. In this fierce battle, calm presence of mind is my armor. Induction dexterity as takeoff and reversal finis in landing, both as sharp as razor. Induction dexterity as takeoff and reversal finis in landing, both as sharp as razor. Well, I deserve a lot of respect and honor. well, I deserve a lot of respect and honor. Invigilating the ups and downs in the vitals with vigor, hand on pulse, eyes like hawk on the monitor and ventilator. No doubt, newer agents and equipments increase the safety factor. No doubt, newer agents and equipments increase the safety factor. But in any case, I have to navigate as a smooth sailor. A complication can disrupt the sails, enough to give me tremor. A complication can disrupt the sails enough to give me a tremor. I manage it boldly like a lighthouse, I stand taller. This branch may not give me glamour. This branch may not give me glamour, but every time when the patient is out, it's like a resurrection that gives me real pleasure, that gives me real pleasure. Thank you so much.
Superb, Vaishali. Each and every word was so true. I think I was living in your poem the way I live in the OT when doing the anesthesia cases. It was too good. Surprise time, friends. Dr. Rajan Joshi sir, he is supposed to make a special announcement for us today. Dr. Rajan Joshi doesn't need any kind of introduction. A multi-talented personality, very successful senior anesthesiologist, poet, writer, director, producer, head of Cultural Society of Thane ISA, Thane IMA, what else? Everything together. Sir, आपके announcement की बेहद राह देख रहे हैं हम लोग. Over to you, Dr. Rajan.
Am I audible?
Yes, sir.
Yeah. Thank you, Manjari, for the wonderful introduction. My sincere thanks to Dr. Dilip Chavan for delivering a wonderful lecture on pediatric anesthesia, and definitely that has cleared some of our doubts, added some more tips. And if he is there on the line, I would like to state that I also use my little finger to give pressure on trachea to see the larynx properly. And I have taught this to my many RGMC students. So I'm happy that we are thinking together. Our thinking is same. Now the announcements are little of non-academic type. First announcement is regarding my first song, Jeevan Sanjeevani Do Yaar. This song is a big hit on YouTube in masses, and the song is having more than 1,14,000 viewers for today's date. And around 10,000 people have subscribed the channel. Many friends, unknown people from all over India and even abroad. I got messages, some from Australia, some from New Zealand, from USA and London, that this is the wonderful thing.
I think sir is having some net issues.
So
Yes,
I thank the audience, and I thank all my anesthetist friends who participated in this activity, who enacted in the video of this Jeevan Sanjeevani song. But I would like, hello?
Yes, sir. Yes, sir. Yes, sir.
Screen is off for me. I am unable to see.
So you have to start the video.
One sec. I'm more in this. Yes, now I am able to see. So thankful to all performers. This song gives message of our 1 hour teaching of CPR just in 4 minutes. And the song is presentation by Thane ISA, and all Thane ISA people enacted in it, and I have produced it for Thane ISA. So what I suggest and request to all the committee members, that we will project this song in every calls activity. It will take only 4 minutes. That can be managed. And even if there is no internet connection, the song can be downloaded on the laptop, or the song can be sent to a concerned person where you are going to do the activity. And if it is downloaded on the laptop, even if there is no internet connection, the song can be played. But this song plays magic. It gives good memories. And again, that those people who are receiving certificates, they can forward it to so many people. So by forwarding the song, we are doing additional social awareness. This is about a request to all the committee members and coordinators of Thane ISA. Now regarding my second song doesn't have any angle of social awareness. It is a funny song based on day-to-day situations in the working of surgeon and anesthetist. Some funny situations arise every day, and those are narrated in this song with all specialties. The song is based on Kalyanji Anandji's famous song, Mere Angane Mein Tumhara Kya Kaam Hai? And this track is recorded in Aurangabad. Voice is recorded. It is recorded in my son's Sanket's voice that we have done in USA, Seattle. And that song is getting uploaded today on 16th of October on YouTube. Again, it is a Thane ISA presentation. And this song will be released in the coming CME in Borivali on 5th of November. Once the song is released and launched in the conference, the link will be made available to all the public and you all can listen to that song. So that is about the second announcement. All of you, please listen the song, please forward to your all colleagues. And the third thing I would like to tell is about a small skit which I wrote in Marathi. स्किटचं नाव आहे उघडा डोळे बघा नीट. या स्किट मध्ये लग्नाच्या मार्केटमध्ये लेडीज अनेस्थेटिस्ट आणि त्याच मार्केटमध्ये जेंट्स अनेस्थेटिस्ट यांची काय व्हॅल्यू असते याचं एक मार्मिक विवेचन मी केलंय. बरेचसे अनेस्थेटिस्ट त्यातनं गेलेले असतील, काही लोक आता जातील सुद्धा. तर या स्किटचं एक संवेदनशील टॉपिक वरती अतिशय विनोदी पद्धतीने ही आम्ही हाताळलेली आहे. आणि याचबरोबर हा एक चांगला अँगल प्रत्येकाच्या डोळ्यासमोर आणलेला आहे. त्याच्यावर आम्ही सोल्युशन पण त्या स्किट मध्ये दिलेलं आहे. पण ते सोल्युशन काय हे आता तुम्हाला सांगत नाही, त्याच्यासाठी तुम्हाला स्किट पाहावी लागेल. ही स्किट आम्ही बोरिवली कॉन्फरन्स मध्ये करणार आहोत. त्याच्यामध्ये मी स्वतः, हेमंत वराडे, डॉक्टर मिनल गाडगीळ, डॉक्टर वैशाली वावीकर आणि डॉक्टर मनीषा घोष हे आम्ही सगळेजण काम करून इनेक्ट करून ही सादर करणार आहोत. ही नाटिका पुन्हा आपल्या कार्यक्रमातही सादर होईल. तर मला शुभेच्छा पाहिजेत तुमच्या सगळ्यांच्या त्याच्यासाठी. आणि चौथी गोष्ट ही सांगायची आहे की एक मोठा इव्हेंट आपल्याकडे पेंडिंग आहे. बरोबर 2 महिन्यांनी तो इव्हेंट आपल्याला करायचा आहे. अँड दॅट द इव्हेंट ऑफ नार्कोटिक बीट्स. नार्कोटिक बीट्स करता मला मनीषांनी सांगितलं की आम्ही IMA हॉल बुक केलाय म्हणून. पण मला असं वाटतं हे 75th इयर आहे. ISA ची 75वी आपण जर सेलिब्रेट करतोय तर आपण जरा मोठ्या प्रमाणावर विल बुक काशीनाथ घाणेकर, साऊंड सिस्टीम चांगली असेल, डेकोरम चांगला राहील, थोडस स्टेज लावता येईल आणि एक वेगळा रिचनेस कार्यक्रमाला येईल. इन केस जर काही फंड्स कमी पडत असतील तर आपण आर्टिस्ट लोक म्हणा किंवा हे आपण काही कॉन्ट्रीब्यूट करू, जसे गेल्या वेळेला आपण केले होते. आणि हा कार्यक्रम काशीनाथ घाणेकरला करावा अशी इच्छा आहे. आणि बिकॉज इट इज 75th अॅनिव्हर्सरी, तर थीम ऑफ 70s आपण ठेवूया. म्हणजे 70च्या याच्यामध्ये जी काय टॉप गाणी आहेत, जी काय टॉप डान्सेस आहेत, त्यावेळेच्या हिरो हिरोईन जसे पेहराव करायचे, मग बेल बॉटम घाला किंवा हे घात, तसं करून एव्हरी म्हणजे आपण तो ड्रेस कोड ठेवूया की सगळं येतानाही तसंच यायचं त्या लोकांनी, परफॉर्मिंगही तसंच राहील, कम्पेअरिंग पण तसंच राहील. आणि कुठल्याही असोसिएशनने आतापर्यंत असं केलेलं नाहीये. सो दिस विल बी युनिक फॉर ठाणे असोसिएशन. आणि ठाणे हे युनिक पाहिजेच, कारण आपण म्हणतो ठाणे तिथे काय उणे हे आपण दाखवून देऊया. सो दीज आर माय लिटिल 4 अनाउन्समेंट्स. आय थिंक एव्हरीबडी विल ॲग्री टू मी. आणि जोरात कामाला लागा, तयारी करा, सिलेक्शन करा तुमच्या आयटम्स काय काय आहेत ते. आणि वी विल हॅव अ ग्रँड बॅश ऑन 17th of December. थँक्यू.
थँक्यू सर. शुभेच्छा आमच्या सगळ्यांच्या तुमच्या बरोबर नेहमीच राहणार आहेत सर. आणि नार्कोटिक बिट्स साठी तर नक्कीच आपण प्रयत्न करूया. नाव द important, not the least thing, is the vote of thanks. At the end of the session, I want to thank Dr. Dilip for his wonderful session, all ISA members who joined on Sunday morning, Dr. Meenal and Dr. Manisha and Dr. Nilima to have showing a faith in me and giving me this opportunity to run this session. Thanks Dr. Sunita, Dr. Vaishali and Dr. Rajan Joshi sir for their wonderful inputs. Thanks Dr. Vineet for the flyers. Thanks Dr. Sweta for the compiling videos. Thanks Dr. Parna for a wonderful PPT. Thanks Varsha and Goenka platform for the Zoom assistance. Dr. Meenal, Dr. Manisha, anything to add in this? If I missed somebody.
Thanks to Dr. Vavikar, who is beside to Vaishali.
Yes. And thanks everybody. Many people are joining from Nasik. Like our president madam is joining from Nasik. Dr. Dilip has joined from Goa. Vaishali has joined from Nasik. So thanks a lot. Thanks a lot for that.
मंजिरी, आपण असं म्हणतो की प्रत्येक कर्तबगार पुरुषाच्या मागे स्त्री असते. इथे कर्तबगार स्त्रीच्या मागे कर्तबगार पुरुष पण आहे, हे आपल्याला सगळ्यांना.
Definitely, sir. Definitely.
Thank you, Dr. Vavikar. Yes.
That's very nice.
So thank you everybody. Enjoy the rest of the Sunday. Enjoy the wonderful session. Thank you to Nilima, especially she conducted it very beautifully. And thank you Vaishali once more for the excellent reading. I think you can share it now on the WhatsApp group. And I request Sunita and Vaishali to share their poems also on the WhatsApp group so that everybody can read them again and enjoy them again.
Sure.
Thank you, Manjiri. Wonderfully you conducted the entire session. And we finished and started in time as usual. Thank you very much. Good day.
Thank you.
Thank you. Just wait.
Bye.
Bye. Thank you. You can move. That's photo राहिलेला बाकी सगळ्यांनी झालं. Thank you. Bye. Bye, Parna. Thanks for joining from Delhi. Parna, are you there? Chalo. Bye.
Bye.
Should I end the session for everybody now? No.